let's talk about a phrase we hear a lot: quality of support. What does it actually mean? Is it just about how we handle a crisis after it explodes? We think it's something much, much more than that. Today, we're going to explore how real quality isn't measured in the chaos, but it's built piece by piece in the quiet weeks before anything goes wrong. So let's start with this big question. When does a crisis really begin? It's so easy to picture it as one single dramatic event, right? A blow-up. But what if that's just the final scene of the movie? What if the real story actually started weeks or even months earlier, quietly, right under our noses?
Here's our game plan for digging into that. First, we're going to try and define what real quality looks like. Then, we'll look at how a crisis actually builds up over time. We'll explore the two different worlds of the system, the rules versus the reality, and what life is really like on the front lines. After that, we'll check out the tools that are supposed to measure need, and we'll wrap it all up by asking some better questions.
All right, first up, defining real quality. This is all about shifting our whole mindset, moving away from just reacting to fires and toward actually preventing them from starting in the first place.
Now, this slide really gets to the heart of it. It lays out two completely different ways of thinking. On one side, you have this idea that quality is built during the quiet weeks. It's proactive. It's about prevention. And on the other side, you have the way we so often end up measuring it, after a crisis, with reactive reports that just focus on that one big incident. The entire system, how it feels and how it works, really depends on which one of these columns you put first.
So here's the definition we're going to work with. Quality of support is everything that is already in place during those quiet weeks. The things that help us recognize when things are starting to slide, to monitor risk, and to make clear, confident decisions long before things escalate. It's about seeing the whole movie, not just the final scene. And that leads us perfectly into how a crisis actually builds. Because, a crisis rarely just appears out of thin air. It's almost always an accumulation of smaller events, dots that we need to connect before they connect themselves into a much more dangerous picture.
Just take a look at this timeline. This is a story that unfolds over 2 months, not 2 minutes. It starts with something small, like a change in sleep patterns. A couple of weeks later, maybe some increased irritability. Then, conflict with others. A missed appointment. See, each one of these signals by itself might not seem like a fire alarm fire, but when you put them all together, they paint a crystal clear and, frankly, worrying picture of escalating risk.
And this chart just powerfully illustrates the scale of what we're talking about. For every 10 critical incidents that get officially reported and kick off a formal response, there could be 90 other non-critical warning signs. These are the subtle changes, the patterns of stress, the little moments that often fly completely under the radar of the formal system, but are absolutely felt by the people on the ground.
So the crucial point is this. Prevention isn't about having a great report after the damage is done. Prevention lives in the raw timeline. It demands that we see and understand the story of change as it's happening, not in some summary report written weeks later. That continuous, unfolding story is the absolute key to acting before danger really hits.
Now, this brings us to a core tension inside the system itself. Let's look at what we're calling the system's two worlds. The high-level world, where the rules get made, and the ground-level world, where life is actually being lived.
You can see the flow right here. It's like a giant funnel. At the top, you've got the government setting the broad framework. Then the ministry creates specific requirements. A regional body, in this case called Community Living BC, organizes the supports. Then agencies are contracted to provide them. But all of this policy, all these procedures, they all eventually narrow down to one single point: the home. That's it. That's where life happens, 24/7.
And in that home, you have these two worlds just colliding. On one hand, you have the messy, unpredictable clinical reality. We're talking medical risks, psychiatric diagnoses, constantly changing human dynamics. And on the other hand, you have the administrative system that's been built to manage it all: contracts, funding allocations, forms, and procedures. These two worlds, they speak very different languages.
And this leads us to a really important structural question. And let me be clear, this is not an accusation, it's a genuine inquiry about design. Within this largely administrative architecture, where does the continuous, professional, clinical oversight actually live? How do we make sure that medical reality is driving the decisions instead of getting lost in the paperwork?
So, let's go right to the very bottom of that funnel we just looked at and talk about life on the front line. This is about the reality of providing that minute-to-minute, day in and day out support. We need to be crystal clear about what a home-sharing provider really does. It is so much more than just housing. I mean, yes, they provide the absolute foundation of life, housing and food, but they also provide daily assistance, direct support for complex medical needs, safety planning, and constant oversight. This is a massive 24/7 responsibility, and it's often carried out under some incredibly difficult and stressful conditions.
And this is exactly why it matters so much. Quality isn't some abstract word in a policy document. It is the quality of a person's real lived life. And that life happens in the home, supported by the people on the front line. So if quality isn't present there, you could argue it doesn't really exist anywhere.
Okay, so if that's the reality on the ground, what tools does the system actually use to understand it and respond to it? This brings us to our next section, tools that measure need. And the big question here is, do these tools help us prevent problems, or do they mostly just help us report on them after they've already happened?
Now, to be fair, it's not like there are no procedures. There are emergency contacts, there are complaint routes, there are critical incident policies. But we have to ask the tough question. Do these things effectively measure and protect quality before a crisis hits? Or do they really only kick into gear after something has already gone wrong? Think about it. A complaint is often a sign that harm has already occurred. It's a lagging indicator.
One of the main tools used in the system is something called the Guide to Support Allocation, or GSA for short. Basically, it's an administrative assessment designed to evaluate a person's need for support across different areas of their life. Daily living, health, behavior, that kind of thing.
But it is absolutely essential that we understand what the GSA is and what it is not. It is an administrative tool that measures support needs. It is not a clinical medical diagnosis. It's a tool for planning, for sure, but it doesn't, and it can't, replace a doctor's actual assessment of a medical condition.
And here we are. This might be the single most important detail about how this tool actually works in practice. Right from the source, the result does not automatically guarantee services. So just think about that. You can have a formal assessment that clearly identifies a growing need, but that piece of paper, that assessment, may not be enough on its own to trigger an increase in support. And that raises a huge practical question. If this assessment doesn't do it, what does?
So, where does all of this leave us? Well, it leads us to our final section, asking better questions. It's time to move past our assumptions about how things are supposed to work and start searching for the measurable realities of how they actually work.
Let's use a metaphor to really make this central question stick. Imagine the whole support system is a two-floor building. In an ideal world, the first floor, the foundation, is continuous clinical monitoring. That's the medical reality. The administrative plan, the GSA, is the second floor, built on top of that solid clinical foundation. The risk we've been identifying here is that maybe the floors have been reversed. Maybe the administrative GSA has become the foundation, and the clinical reality is just kind of slotted in on top of it. The question is our system built on a clinical foundation or an administrative one?
So this explainer isn't about giving a final verdict. It's really about learning to ask better, more specific questions. And it leaves us with some really critical, measurable ones. If this thing called quality support exists, where are the specific criteria for it written down? What mechanism actually guarantees more support when an assessment shows the need is real? And how is any of this measured before a crisis, not after? Next time, we're going to go looking for those answers. We're going to follow the money and the paperwork, and we're going to dive right into the actual budgets, contracts, and reviews.